everyone. So on behalf of the Columbia Population Research Center, which is funded by the National Institutes of Health and the Provost's Office, I want to welcome you all to our monthly seminar. I'm so pleased to introduce our speaker, Dr. Helena Hanson. Dr. Hanson is an assistant professor in the Departments of Anthropology and Psychiatry at NYU and a research scientist at Nathan Kline Institute for Psychiatric Research. She earned her MD PhD in cultural anthropology as part of Yale's NIH-funded medical scientist training program. She's published widely in clinical and social science journals from JAMA to Social Science and Medicine on faith healing of addiction in Puerto Rico, psychiatric disability under welfare reform, addiction, pharmaceuticals and race, and ethnic marketing of pharmaceuticals with funding from NIDA, the Mellon Foundation, and the Robert Wood Johnson Foundation. And just as a personal note, since I met Helena many years ago when she was an RWJ fellow, I've always wished that she were here instead, but I guess the good part is that she's not so far away on the subway, and we're very happy to have her here with us today.
Thank you. Thanks so much, Jennifer, for that generous introduction. And it is true that my roots here go very deep. Is the mic not working? Maybe I just need to clip it a little closer. Can you hear me now? So yeah, my roots here in particular at Mailman go very deep. Not only was I a Robert Wood Johnson Health and Society Scholar here a long time ago, but not too long ago. I see some of my fellow scholars in the audience. But I was here as a college intern. And I won't tell you how many decades ago that was, but that's where I started to get these funny ideas. I was working at the HIV Center with Bob and Mindy Fullylove at the time. And I started to get these funny ideas from working with them to somehow combine social science and medicine. And they discouraged me all the way along on the medicine part. They knew how harrowing that part would be. But I was really bullheaded. And they continue to be my adoptive parents. So I feel very much like this is home for me, and it's an honor to be back. And I wanted to start off with a comment about social science and medicine, since this is, I think, the hub of social science and medicine. And that is, I got interested in addiction on many different levels. One of them was personal, my family history. And I won't get into the details of that right now, but I could if you're interested. Another is that addiction is such an interesting problem for someone who is an anthropologist and a psychiatrist, because there's no cultural consensus about what kind of problem addiction is. Is it a moral problem of spiritual uplift and renewal, or moral deficit? That was kind of my dissertation work on Puerto Rican Pentecostal street ministries. Is it a biological problem, a problem of neuroreceptors and finding the right molecule? And working in the psychiatry department at NYU, I see that evolving every day, that biological model of addiction. Or is it a social problem? And I think that's where I feel most at home, thinking about how very different addiction looks by time, place, community, context. So layered onto this controversy about what kind of problem addiction is the role of race. And that's what I'm going to be talking about today. So race, of course, plays a large role in drug policy and our approaches to addiction in this country. It's really a central organizing principle in that our economy was founded legally and socially on enforced racial segregation to create a second-class labor force of blacks and migrants to produce goods for an exclusive white consumer market. And in a very funny way, I am tracking the very same thing when it comes to opioids right now. So this dynamic persists in illicit drug markets, and I'll also argue biomedical industries. I'm going to share a case study of hidden yet active maintenance of white exclusivity in medicine as a cause of what we often call, quote unquote, health disparities in medicine and public health. So health disparities among underserved minorities groups that we typically describe in a passive manner as, quote unquote, lacking access to care. That's the way in the clinical world we talk about it. We usually take whiteness for granted, and we rarely examine whiteness as something that requires cultural enforcement that in itself creates an extreme environment driving social patterns of addiction and health. So whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people. Bear in mind that pharma is probably the largest single economic sector, pharma and healthcare together in our country, and probably globally as well. So it involves the mutual racialization of drugs and people. Drugs can be white, as in targeted to white people, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I'm going to be drawing from my forthcoming book on white opioids to shed light on the racialization of narcotics. And I want to start by saying that for over a century, narcotics have upheld U.S. racial segregation in terms of prohibitionist policy versus protected legal pharmaceutical markets for a white middle class. They guard racial boundaries and hierarchies of deservedness and moral blame. They tap into our conflicting cultural logics about whether addiction is moral, social, or biological, and they're major drivers of the economy and national politics. So one statistic that you may already have run across is that we in the U.S. consume 80% of the world's opioid supply. We make up less than 5% of the world's population. And billions of our tax dollars, as you all know, are dedicated each year to drug war enforcement in inner city neighborhoods and in Latin America. So while narcotics have long been criminalized through association with marginalized racial groups, I'm just going to give you some fun historical images here, such as turn-of-the-century images of Chinese opium dens, Negro cocaine fiends in the South, and Mexican marijuana madness. We don't often look at how this dynamic can work in the opposite direction, how a drug can become unmarked, how it can assume whiteness within a racialized pharmaceutical logic. And yet this process of pharmaceutical whiteness is at the core of the widely asked question, why is the life expectancy of whites suddenly falling in the U.S., while life expectancy for almost every other racial group is rising? And how did opioids become their primary immediate cause of excess death? So this is a question that's prompted a national discourse of the quote-unquote endangered white male. And my answer to the question of how opioid overdose became white is different than the received wisdom that unemployed whites in the post-industrial Rust Belt turned to opioids for solace. So that might be true, but it begs the question of why opioids, why white people, and why now? I argue that the current generation of opioids were designed to have white racial identities and that our stratified healthcare and justice systems, the biotechnologies and social technologies shaping opioid consumption, reinforce racial hierarchies while at the same time harming whites. I encountered these technologies of opioids and whiteness in the late 1990s. I was a medical student. I was working in a clinic that was running early clinical trials of buprenorphine, now commercially known as Suboxone. My supervisors were really excited about buprenorphine. They said it was about to change the culture of medicine, that it was going to make addiction a mainstream chronic physical illness, treatable in the same settings in primary care clinics, using the same methods, long-term maintenance pharmaceuticals as asthma, diabetes, and hypertension. And I was in this clinic during the late 1990s rise of prescription opioid use in the suburbs, when opioids became the most prescribed drug class in the U.S. And overdose followed closely behind. All of this was happening in the midst of a national national move towards stop and frisk sting operations in Black and Latino inner city neighborhoods. So let's see. This was my slide, Incarceration. And that put the U.S. prison population well above all other countries in the world. I don't know if you all recognize this slide or the law that it referred to, the 1986 Anti-Drug Abuse Act, which mandated minimum sentencing, prison sentencing for 1/100th the weight of powder cocaine to crack cocaine. But so here, incarceration rates took off as a result. I found a puzzle here. That is increasing white opioid use in the midst of an intensified inner-city drug war. And this puzzle has become a part of my study of addiction pharmaceuticals, for which I've observed dozens of drug policy and addiction science meetings, observed interactions in clinics over 4 years, and interviewed almost 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers, and patients. So my punchline, I'll give it now up front, is that I discovered an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. The story is invisible by design. It was only through sustained participant observation and interviews with key actors in the story that I've been able to unravel the threads. So let's start with Suboxone. It's easiest to see its racial identity by comparing it to its predecessor, Methadone, the only other opioid that can legally be used to treat opioid dependence in the U.S. So here's a bar graph from the first and last nationally representative study to compare buprenorphine patients to methadone patients by race and class. So this was a study completed in 2005, and it's still the only nationally representative study that we've got. I've done some mapping of data from New York City since, showing that these trends still persist. And here, what this particular map shows is that the patterns of buprenorphine prescription and methadone prescription residents of people who use either drug are pretty much the inverse of each other. But what we don't know from these graphs is by what process did these drugs, buprenorphine and methadone, gain their racial identities? So for that, I want to go back in time a little bit. Let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for blacks is twice that of whites, and the mafia gains control of Asian heroin imports, recruiting a sales force from black and Latino inner cities. Meanwhile, Rockefeller University diabetes researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency, analogous to diabetes, insulin deficiency and diabetes. He publishes findings from the first clinical trial of methadone maintenance. And the study subjects are African-American heroin-injecting men from Harlem. Its outcomes of decreased criminal activity and increased employment at 6 months bring it national attention. So by 1970, news of methadone as a pharmacological solution to urban heroin use reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. The names are kind of flipped here. Nixon on the left, as you might have guessed. So Jaffe targets inner-city blacks and Latinos, as well as returning Vietnam veterans, with methadone, the major weapon in Nixon's war on drugs. And in order to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing. Due to community resistance, the methadone clinics, were located in marginal neighborhoods in the city, remote from other medical services. So methadone has inhabited this kind of quasi-medicalized, quasi-punitive space ever since. Let's fast forward to October 8th, 2002. A new kind of opiate problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a minimally addictive pain reliever, quote unquote. Most of these newly addicted people are white, and many of them are middle to upper income. The FDA has just approved the synthetic opioid buprenorphine, commercially packaged as Suboxone, for maintenance treatment of opioid dependence in private buprenorphine-certified doctors' offices. Pharmacologically similar to methadone in that it blocks the opiate receptor in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone remains restricted restricted to DEA-regulated clinics with directly observed dosing. Office-based buprenorphine represents a reversal of national drug policy. It's the first time since 1914, the 1914 Harrison Act, that generalist doctors are permitted to use opioids to treat opiate addiction. To accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. Buprenorphine, pharmacologically in the same drug class as methadone, had to be whitened. So this is Mike in an ad for Suboxone, seated in his Ohio diner with, you can see here the American flag flanking him. And he's talking about returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following an injury in his diner when working. And I'll just let you ponder a little bit the imagery of that, the Americanness and whiteness of that. I wish I had time to show you the ad, but you can pull it up on NAABT.org, National Alliance for Advocates of Buprenorphine Treatment.org, which is sponsored by the manufacturers of buprenorphine. But I argue that this ad was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. And I'll give you my analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. That is, social technologies such as neuroscience, policy, and industry strategies to maintain racial boundaries around biomedical uses of opioids. My scheme is informed by whiteness studies, an offshoot of critical race theory, and it proposes that, one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries. Two, that white race is unmarked. It's the assumed norm in this country. It's rarely explicitly named, either in public policies or in the media. Now that is changing a little bit with the coverage of the white opioid crisis, but still, even in news coverage of the crisis, I actually did a media content analysis with colleagues to find that people were described with coded language, suburban, or described in terms of which neighborhood of a city they were from, so not using the term white. This also relates to a colorblind ideology that reproduces white privilege by eliminating racial references from seemingly universal policies and practice. Some of you may recognize that term, colorblind ideology, for example, from Michelle Alexander's book, The New Jim Crow, about mass incarceration. So whiteness is also defined by its other. White and black are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for whites who've had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class housewives a century ago, then moving to post-World War II barbiturates, stimulant diet pills, and later Valium, otherwise known as suburban mother's little helper. Now back to prescription opioid pain relievers. And then finally, white privilege has its costs to whites. Not only do white consumers pay inflated prices for patented prescription opioids, they also pay with their lives in the form of overdose by lethal substances to which they have, quote unquote, privileged access. So the four technologies of whiteness that I'm going to discuss include addiction neuroscience, new biotechnologies, regulatory structures, and marketing. And I'll start with the least visible technology of race making, which is brain science. Let's place buprenorphine development on the backdrop of President Bush I's decade of the brain. This was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. Alan Leshner, who was then director of NIDA, National Institute of Drug Abuse, lobbied to rebrand addiction as, quote unquote, chronic relapsing brain disease. Leshner's ambition was shared by other leading NIDA researchers who co-authored this widely cited article in JAMA in 2000 with the title Drug Dependence, a Chronic Medical Illness. And in it, they argued that narcotics addiction was comparable to diabetes, hypertension, and asthma in terms of heritability, treatment adherence, and relapse rates. And as such, that it should be treated in a similar way. So we're starting to foreshadow office-based buprenorphine. The scientists involved in this movement had a clear social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition. And what they didn't see was that scientific universalism, with its implicit assumption of a standard white male subject, and the unequal ways that biotechnologies are disseminated, that those things would actually enhance the social stratification of addiction. So for instance, brain imaging like this, by taking the subject and his or her trappings of gender, race, and class out of the picture, and actually by taking the offending organ out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. And in neuroscience, in laboratory studies, addiction is further reduced to molecular action at neuroreceptors, the ultimate disembodiment of addiction. The apparent universality of this molecularized model implies an assumed white norm and excludes the social or political from addiction. Ironically, the scientists involved wanted to counteract a punitive drug war mentality by erasing the social and cultural foundations of drug use. This was a neurobiological version of colorblind ideology that unconsciously unmarked and whitened opioids by molecular means, paradoxically further racializing drug policy. Okay, so now I'll start to get towards what I mean. That's Noro Valkow, by the way, director of NIDA. So the next technology of whiteness is new biotechnologies. Neuroscientists were unwitting accomplices in a more consciously racial industrial strategy. Building on the neuroscientists' ideology of technological solutions to previously socio-political problems, in 1996, Purdue Pharma got FDA approval for OxyContin as a quote-unquote minimally addictive pain reliever suitable for chronic management of moderate pain. This was based on its patented sustained release capsule technology, which in theory lowered the reward for drug users by preventing an initial rush. At the same time, the National Joint Commission on Hospital Accreditation called for pain to be aggressively monitored and treated as the fifth vital sign in clinical care. And those things together led to widespread OxyContin prescription for moderate pain, such as that due to lower back injury. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. OxyContin users that were interested in rush quickly learned to crush and snort or inject the contents of these sustained release capsules, oxycodone being much more potent than morphine. What followed has been called a public health disaster, with vast industries of prescription pill mills cropping up across the country, followed by unprecedented opioid overdose rates. After steep increases in opioid misuse and overdose, public pressure mounted for intervention. In August of 2010, just as the original patent of OxyContin was running out, Purdue Pharmaceuticals introduced its tamper-resistant time-release formulation, embedding OxyContin into polymers that convert tablets into gummies should someone try to dissolve and inject the contents. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, non-white street markets. Another biotechnology developed specifically in response to white suburban and rural prescription opioid use is buprenorphine itself. Commercially released in a combination pill with opioid antagonist naloxone and branded Suboxone. Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's combined causes withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone can't be absorbed into the bloodstream through sublingual under the tongue administration. And buprenorphine also posed a lower risk of overdose than other opioids. In the 1990s, NIDA subsidized Suboxone's manufacturer to test it for use in addiction treatment. and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from Narcotics Schedule II, where OxyContin and methadone fall, to Schedule III, along with common products such as codeine cough syrup. This is what made it possible to prescribe Suboxone in office-based generalist doctor settings. In a race and class stratified healthcare system, such as we have here in this country, where access to generalist doctors is often limited to those who can pay, patented technologies designed for private office delivery in themselves encode race, white race, and middle class. So the third technology of whiteness, regulation. Although by 2004, prescription opioids overtook heroin as the primary opioid of abuse in the US, the arrest rate for their illegal possession was 1/4 that for possession of heroin. Arrests for illegal sale of prescription drugs was less than 1/5 the arrest rate for the sale of heroin. Not coincidentally, the non-medical use of pain relievers was twice as high among whites as blacks at that point, while rates of heroin use among blacks, Latinos, and whites were almost identical. Since suburban and rural whites were not politically supportable targets for law enforcement, the DEA and other regulators focused their surveillance and enforcement on prescription opioid prescribers and suppliers, pharmacists, for example. One sign of this has been the spread of prescription monitoring programs, which have been enacted in 49 states, half of which mandate prescriber participation with threats of loss of license and prosecution. So here in New York State, for example, if I prescribe a narcotic without checking the patient's database to see if they've been prescribed other controlled substances, I'm subject to loss of license and criminal charges. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act, Data 2000, that was passed by Congress in 2000, enabled any certified physician to prescribe Suboxone in the privacy of their offices. In congressional debates leading to the passage of Data 2000, there's a clear emphasis on a quote-unquote new kind of user, one that's young, suburban, and quote-unquote not hardcore. That is implicitly white. So this is another example of the coded language that one has to decipher if one wants to hone in on whiteness. Alan Leshner, who was then director of NIDA, testified that bup is uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end quote. In the same congressional hearing, then Health and Human Services Director Donna Shalala notes that buprenorphine, as an alternative to methadone, would serve a new kind of addict, quote, including citizens that would not normally be associated with the term addiction, end quote. Data 2000 kept the methadone system intact and did nothing to alter the drug laws that mandated inner-city heroin users to prison, but it did create a new treatment track for those who had the resources to take advantage of it. To give additional assurance to the DEA that buprenorphine wouldn't spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine. It's the first and only prescription drug in the U.S. to come with such a requirement. Public sector doctors tell me in my interviews with them that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics don't provide incentives or time for them to pursue this kind of additional training, while prescribers in the private sector can charge fees of up to $1,000 for a half-an-hour induction visit for buprenorphine. So the shortage of public sector buprenorphine prescribers, along with the cost of buprenorphine, $5 to $10 per tablet. It's actually now also patented strip formulation, which is even more expensive, versus 40 cents a dose for methadone. Those things have kept buprenorphine in the public sector for quite some time. And I can get into this later in our discussion, but that is a moving target. So now the manufacturer, I think, has begun to look to the private sector as a new market. And also on the public administration side, there's a push to introduce buprenorphine into practice. Okay, ethnic marketing. So this is the fourth technology of whiteness. OxyContin's legendary commercial success hinged on its designation as a minimally addictive opioid analgesic. When OxyContin was under review at the FDA, Purdue estimated the addictive potential of OxyContin to be less than 1%, based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted the claim that the addictive potential of OxyContin was less than 1%, based on these trials, and enabled Purdue to open an opioid market that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain. So they were able to open a new, much larger market of patients with moderate chronic pain, including lower back pain, hiring almost 700 drug reps to canvass a call list of over 100,000 physicians. Purdue targeted generalists in primarily white suburban and rural areas, serving patients that the public and the DEA did not think of as high risk for addiction and for drug trade and diversion. Purdue's strategy was quite successful. It led to a 10-fold increase in prescription opioids nationally, prescription of opioids nationally, with disproportionate uptake of OxyContin in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latino drug users, suburbanites addicted to OxyContin are portrayed sympathetically in the media as victims of overprescription or as people struggling with real and existential pain. So this is just one of myriad images in the media. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with the new prescription drug monitoring laws that I described, led many of these legally prescribed OxyContin users to look for heroin when pills became hard to get. And one consequence of this has been a whitening of the media coverage of heroin users, which have long been portrayed as Black or brown. So this is a school teacher, and this is a college athlete who went public with their heroin addiction. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. And I'll just allow you to do your own analysis of the imagery. This is the homepage of the National Alliance for Advocates of Buprenorphine Treatment, sponsored by Reckitt Benckiser Pharma. So you can ponder what kind of person looks for their treatment on the internet using websites like this. The manufacturer also put on this website a link to a Suboxone prescriber locator service created by SAMHSA, the Substance Abuse and Mental Health Services Administration. So browsers enter their zip code, and they get a list of Suboxone prescribers in their area, most of them in private practice. These strategies created an exclusive yet highly lucrative segment of the market for Suboxone, making it a blockbuster drug. So beginning in 2012, it generated over $1.5 billion per year in sales, second only to OxyContin, which in that year generated $3 billion in sales. So, in conclusion, this racial segmentation of markets into licit and illicit, white and Black, clinical and recreational, as dictated by the war on drugs and by opioid manufacturers, creates a moving target of time-bound patents on new technologies targeting white middle-class consumers. And the forerunner in all of this was Bayer Pharmaceuticals' own heroin, marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives in 1898. And because I'm here at Mailman School of Public Health, I want to take a moment to ponder that this could be otherwise. In France, where buprenorphine was adopted for generalist physician treatment of opiate dependence in 1996 in the midst of an overdose and HIV epidemic, it was billed not as a stigma-reducing agent for a middle-class market, but rather a public health intervention to stem overdose and HIV largely among low-income immigrants. Buprenorphine was widely adopted by primary care doctors in poor communities in France. In a country with, by the way, universal health care, that's kind of the missing piece of the equation. And as a result, the opioid overdose rate in France dropped by 80% in the first 7 years of buprenorphine's use. Here in this country, where buprenorphine was introduced in 2002, overdose rates have actually quadrupled in the first decade after the introduction of buprenorphine. And based on my fieldwork with white and non-white people trying to access buprenorphine and stay on buprenorphine, this is an important point, it's a medication that's a maintenance drug, I suggest that the public health potential of buprenorphine is limited by our racially segregated and market-driven healthcare system, which orphans patients that have patchy health insurance coverage and tenuous access to prescribers. So this is a problem that really applies universally. The French example here highlights alternatives, though, to the binary of commercialized biomedical versus punitive law enforcement frames for drug policy. In the long run, we may be able to use the current moment of despair over white deaths to build the case for a less market-driven healthcare system, for public health and social determinants-based approaches that highlight the damage to both whites and non-whites of our racialized industrialization of health. In the short run, we'll need to shed light on the impact of unspoken racial politics of drugs through initiatives such as racial impact assessments of new drug policies proposed by my colleagues at the Drug Policy Alliance, working with the Black and Latino caucuses of the New York Assembly, and modeled after environmental impact assessments. We need proactive measures because in both the prevailing U.S. frames of criminal justice and biomedicine, addiction is individualized and based on a logic of consumer choice, making systemic racialization hard to see and making it easy to maintain two tracks of narcotics policy, a clinical track for the white middle class and a criminalized track for the rest. I realize I didn't put these slides in here, but one sign that this two-tiered response is definitely well underway can be found here in New York City, where Staten Island, which some of my colleagues here at Mailman have documented, has had for several years the highest opioid overdose rate in the city of all the boroughs, where Staten Islanders have organized and worked out with the DA in Staten Island to offer everyone arrested on opioid possession the option to go into treatment and be matched with a peer who's in recovery as opposed to going for sentencing. Staten Island remains the only borough in the city to have that. It's called Project Hope, and they claim that in the last year, 2017, they diverted over half of their arrestees from sentencing into treatment this way. So South Bronx, which now reports the largest number of opioid overdoses in the city, has no such program in place and continues with a law enforcement heavy approach. And we know, since we're here at Mailman, about the health consequences of incarceration that has lots and lots of implications for not only the people arrested but their families, foster care placement, lots and lots of health outcomes, in addition to increased risk of opioid overdose on the basis of incarceration. So I'll just end with not heroin ad, but this one. Racially segregated drug policies and lucrative prescription narcotic markets can only be sustained if there's a separate route to categorize and discipline drug use among whites, and that route must appear, at least on its face, to be race neutral. This has costs that are borne by whites who pay inflated prices for these drugs and sometimes pay with their lives. So the ambiguity of the Greek word pharmakon, its dual identity as medicine and poison, is exploited in this white war on drugs that wasn't, in which unprecedented profits are made in the liminal space between licit and illicit sales, a space that's protected by its symbolic whiteness. Thanks. I hope I left some time for discussion. Yeah.
You mentioned when we were speaking earlier this morning that you just came from NIH.
Yeah.
I'm wondering, how do you express this kind of analysis to our colleagues at NIH?
What a great question. Because I spent the last 2 days experimenting with that. And I just did it. No, really, I gave them a version of this, and I don't know what the impact is going to be. The meeting, one thing I didn't mention is they started out the meeting with Ann Case and Angus Deaton. And I think that was their attempt to put a social frame. They're economists. For those of you who don't know the study, Angus Deaton is a Nobel laureate economist. Angus Deaton is the Nobel laureate economist. Ann Case is his wife, who's also an economist at Princeton. And I think because white people are involved here, and the fact that they're economists, and one of their preoccupations is the decline of the white working class, this article, on one hand, may have led to the results of the last national election because it definitely fed into this discourse of the endangered white male. On the other hand, though, it has introduced a language of social determinants into the causes for addiction that wasn't there before. It's really fascinating. So people are now taking Ann Case and Angus Deaton's argument that what we're seeing is a disease of despair, that this addiction crisis is the despair of the white working class that now is facing really rampant unemployment in the face of deindustrialization, the Rust Belt, rural areas, et cetera. So for the first time, we are having this national discourse of the social determinants of addiction that was not in place before. So I think that the organizers of this meeting that were in the Office of Behavioral and Social Science Research at NIH thought of this as a social science move to put them in the beginning. Very oddly, though, the way that they had of talking about race, I realize they're economists. They are not sociologists. They are not anthropologists. They're starting to muse about the reasons why black overdose wasn't at the same level you would expect if it's a disease of despair and deindustrialization, that blacks would be dying off. And they came around to some very odd suggestions like religion as a protective factor. And so I just decided, because I am at a place right now where I am going to, with you, for example, pursue NIH funding, but I'm positioning myself not to be dependent on that, I kind of needed to speak up. So I started asking about the fact that, because Angus Case and Angus Deaton and Case had a very long historical view describing the decline of the white working class in the U.S., and I pointed out that probably what we're seeing is that blacks fell off that wagon decades before whites, because they were last hired, first fired. They didn't have the same protections. So what we're seeing among working class whites now, we probably saw decades prior. So blacks had this really tiny blip of post-war, a post-war period where they were able to partake, and then they fell off quickly. And then we saw much earlier epidemics, generations of people who died from HIV injection-related HIV, the mass incarceration that I just described. So we're talking about communities that have already been completely and thoroughly decimated, and the white working class is kind of coming along later. So we had a good conversation about that, and I was glad that I spoke up, because I now have a communication going with Ann Case where we're talking about these things. But it is hard within an environment of NIH to figure out, because they are actually quite behind. The first day of this meeting was devoted to pain management. How can we get doctors to prescribe less opioids and to use alternative pain management strategies? Several people attending the meeting pointed out, you've already missed the boat. We're now regulating the heck out of opioid prescribers, and the prescription rates are going down, but we're talking about a different phase of the epidemic. We're talking about heroin, fentanyl, et cetera. We're also talking about local cultures of use where people are initiating with heroin. They're not necessarily starting with opioid pills. So it was only by day 2 that like I told you, we're hearing from people from Vancouver who are really out in the front with harm reduction, with user participation, with people using heroin in unions. And this was jaw-dropping for the NIH reps. Unfortunately, day 2, when they rolled out these kinds of people, was when Francis Collins was not in attendance and Nora Valkow was not in attendance. So they got really updated on improvements in pain management, and they didn't hear these other perspectives. But I thank you for that question, because I bet a lot of people in this room are trying to figure out, how do you get the NIH to kind of go a little bit further along? They're often the last, because and especially under this administration, I can only imagine what they're negotiating when they come out with new program announcements and funding priorities. So I think we just kind of have to talk about it and put it on the agenda. And there are people inside, you know better than I do, because you know these folks. There are people on the inside of the NIH who are quite forward-thinking, and so they need us on the outside to speak loudly so they can cite us to say, we're far behind, we don't need to pour all of our money into pain management anymore. And we do need to look at community level factors and community organization and how to activate people. I don't know if I answered your question. Yeah.
123 people on the live stream.
Oh, whoops.
And I should know to use the mic. So there's 123 people also participating, and one of the questions there is, how is this work being shared with criminal justice, substance use, mental health systems? It would appear to affect change. There would need to be a cross-system response. Can you talk about that?
That's an insightful question, and I would like to talk with the person who asked it. How can we collaborate to do that? That's a huge job. It's going to take a lot of us. So I started off with this particular line of work within the academy, but my co-author is Jules Netherland at the Drug Policy Alliance, and she, I think, has been my secret weapon in terms of thinking about policymaking and systems. And I realized that researchers and social scientists cannot do this alone. She's trained in sociology, but she's been at DPA as a lobbyist and working at several different levels of policymaking. And it's just a totally different world. Like, nothing in my PhD or medical training would prepare me to think like a policymaker. But she's been doing this for a living for a while, and so it's just so lovely to collaborate with her. And so I know that all of you in this room are doing policy relevant work. And if you don't already have a partner who works in the world of policy, I would highly recommend finding one, because that's the only way I've been able to start thinking a little bit further down the line and not just stopping with what sounds like an overwhelming critique. I mean, what do you do with all this? Where do you go with it? Julie actually has some ideas, and she has colleagues who are doing things like the racial impact assessment. But I think ultimately, I'm hoping we can leverage this phenomenon to go for things like universal health care, to really think much bigger, to think about pharma and the untrammeled way that they're able to just commodify everything. I think that we can, if we're smart about it, harness the upset and anger, but we have to do it in a way that doesn't just stop with whites and suburbia. We have to be more inclusive, and that's why I'm trying to get this message about the hidden whiteness of it all out.
Hi, I was wondering, in this presentation, you didn't talk about Vivitrol at all, and I was wondering, since that's kind of being marketed as this new kind of miracle drug, if you've looked at all of the racialization of that type of drug, or just, looked into Vivitrol.
Thank you. That's a great question. So I haven't systematically looked at it myself, but my colleagues that are studying Vivitrol say a scary thing is happening in that criminal justice is picking it up. They really love the idea of injecting someone with something that's going to last a month and prevent them from using illicit opioids, right? That's kind of a dream. And what some of my colleagues at Einstein Montefiore are tracking right now is the possibility that we're actually increasing opioid overdose rates that way because we have no follow-up care. Right? So you've got a captive audience in the criminal justice system. You inject them with this thing that lasts a month, and you release them. They have no follow-up. They come off of the injectable naloxone, and they actually have a lower tolerance and much more physiological vulnerability to overdose. So that's one of the studies that we're now working on designing to try to document this. This magic bullet thinking gets us into problems at every step of the way. And I do think it's a little creepy that it's the criminal justice population that they're targeting, and how consensual really is that. Vivitrol has not been horribly popular on the private market. The company that manufactures it, Alkermes, they had to figure out really quickly an alternative market because they just couldn't get people who had a lot of choice and liberty to make that kind of commitment to take a month-long depot formulation. So it hasn't been a big seller otherwise.
Speaking of magic bullets.
Yes.
Speaking of magic bullets and drugs and pharmaceuticals, have you or any of your colleagues thought about PrEP?
You mean the analogies between PrEP and this?
I mean, just how that's marketed.
You want to say a little bit about that?
What?
It sounds like you have something to say about that.
I may have something to say about it at some point, but it certainly occurred to me in terms of, creating a market for people who are not sick, all of that, all of these issues that you that's why I wrote them all down.
And what about continuity of care in this crazy healthcare system, if you can call it that? And then what about resistance? If people go off and on, it could make the epidemic worse. Yeah, I think there are a lot of parallels. Thank you.
We have another question from the live stream. They're wondering about Project Hope in Staten Island, and will that be introduced to people of color in the South Bronx? Are people of color overdosing is that seen in itself as an epidemic?
That's such a great question. So my colleagues who work in this area, what they're trying to do is get attention to the fact that the South Bronx needs a Project Hope. The reason they have it in South Staten Island, of course, is you're talking about empowered people, racially and socioeconomically empowered people who organized with the DEA. And then also this very different dynamic that Sonia Mendoza, my colleague in the audience here, documented in her paper based on fieldwork in Staten Island. Such a different dynamic of othering addicted people. So in Staten Island, there's very much a discourse of, these are our neighbors, these are our sons and daughters. It was very remarkable the way that opioid addicted people were quite differently framed in Staten Island. And so I think that was the fact that the community is organized and empowered. And also, as a part of that, they don't other their addicted members in the same way. So the DEA was persuaded there. It probably would take a different strategy in the South Bronx. I know that the commissioner of the Department of Health is really interested in the South Bronx. She may be able to make some headway from the top down and hopefully partnering with community organizations there. But they're talking about, as many researchers in this room know because they work in the South Bronx, we're talking about a community that has just had decade after decade and generation after generation of displacement and shredding of its social and political networks. So it's such a different context, and it's going to take a different kind of intervention to bring a Project Hope there. And so I'm hoping that we collectively who are interested in social justice can make that a priority to see to it that these things do disseminate out. The other thing is mass incarceration is the rates are going down. And probably so one thing is there have been a bunch of exposés of the heavy racial injustice of mass incarceration. But the other thing is that prisons and jails are so expensive for the state. So what we're now dealing with is probation, a rapidly growing population of probationers. And so I think we need to very closely monitor that with regard to addiction, treatment, overdose risk. How is that going to play out? Because it's a different scenario, but it's equally potentially unequal and abusive.
Hi, thank you. Thank you so much for the talk. So I guess I'm curious how you're thinking about
intentionality and sort of systemic conflict of interest, because what we know from Joe Dumit about health as an industry, I mean, this really gets to the absolute core of, can it be an industry? And as he explains, it has to be grown. That's just, beyond anyone's bad or good intentions. That's the logic of it expanding, right? The exploration of new markets. And the question is, there's certain, market explorations that lend themselves to, I think it seems like racial categories are always going to be one, ready market. So I'm just curious about, what you're telling us really gets to the core of this systemic conflict of interest, right? So, yeah.
Yeah, exactly. So I mentioned Jules Netherland of the Drug Policy Alliance. We're working together on this book version. And one thing we're trying to theorize is racial capital, because that's really, it's really the racial incentives in the way that this was marketed, et cetera, that led to the form that the opioid epidemic took. Joe Dumit's book, I think you're referring to Drugs for Life. I come back to that book a lot because I think he's absolutely right. We've seen this shift within pharma from a focus on developing treatments for acute illnesses to a shift to treatments for chronic illnesses, because they're much more lucrative. They're long-term commitments. But not only treatment for chronic illnesses, but treatment for risk factors for chronic illnesses. So we're not even treating the illness, we're treating the risk factor for the illness. And that, of course, is a completely unrestricted size of market. All you have to do is toy with the indicators for risk, and you can grow a market tenfold, right? You just play around with the level of blood pressure that's considered at risk for hypertension, and all of a sudden you've multiplied the number of people for whom antihypertensives are indicated. So I think he does make this compelling argument that the way that pharmaceuticals right now have been commodified is totally at odds with public health principles. So how do you approach something like that? We again harness this moment of a crisis where a lot of Americans get it. They're not getting health coverage. They're not getting health care. They're paying a whole lot of money and getting nothing back. Hopefully highlighting other peer countries, because Americans are so provincial. They have no idea that there are other ways to go about this. And all we have to do is look to Canada, look to Europe. There are lots of countries that, right. So maybe we can use the opioid crisis as a way in to say, well, why aren't all these other countries having the same level of overdose death as we are? There's some things they've got happening and in place that we don't have in place. So maybe this is the time. Without that kind of holistic view, I think it's going to be hard, because pharma has taken advantage of this all the way along. And by the way, when I was prepping for this meeting at the NIH, I was realizing that they're still stuck in the mode of biotech will solve all of our problems. On day one, Nora Volkow and Francis Collins started off talking about all these lovely private-public partnerships they've established with biotech firms and pharma to develop new treatments, biotechnologies, extended release, injectables, et cetera. So they're very much still stuck in that. And the point is that, of course, biotech will not get us out of this. It just won't. And in fact, if you think about it, the U.S. is the place where OxyContin was developed, buprenorphine for addiction treatment was developed, Opana was developed. All these opioids were developed here with, by the way, government subsidies. So I mentioned lightly that NIDA had subsidized the clinical trials of buprenorphine for opioid addiction. They actually gave $27 million to Reckitt Benckiser to do those trials. So, and what has it gotten us? It's gotten us a huge opioid overdose problem. So, so we can't engineer ourselves pharmaceutically out of it. And so that's where what I've been calling social technologies come in. We have to think about social technologies, and that's where our peer countries are way, way, way ahead. And that's why I'm so glad you all are training, because you're going to be ready. You're going to introduce the social technologies when the American public wakes up and starts lobbying for systemic intervention. Is that it? Great. Thank you.
Thank you. People on the live stream also wanted to know if they could possibly have the PowerPoint. Is that possible? If you PDF it and we could send it out to them? But it always depends on the speaker. You don't have any pressure.
Yeah, I could do that.
Yeah? Because
I'm trying to remember. I vaguely remember signing something. Did I get
that was the release form for like reporting.
Oh, I see. It wasn't for that.
Yeah.
Okay.
It's up to you, and if you want to modify it or
Sure. No, I could send this version.
Yeah, and
would I
we
email
always
it to you?
PDF it. Yeah, you could just send it to me, and then we just send it out to. There was a lot of discussion about it. Oh my God, this is so great, but I think I need to look at these stats in more detail. There was those little kind of questions.
Don't look to my slides for the stats.
Yeah.
That's not the point of it.